So today's topic is pregnancy
Yes,
with
ma'am.
previous
Yes,
cesarean.
ma'am.
So what is post-cesarean pregnancy? Well, pregnancy with history of previous cesarean section means patient will be always second gravida or more than second gravida. Is it? She can't be primary. Yes or no? Pregnancy with history of previous cesarean section. In her obstetric history, she had first pregnancy or second, third pregnancy by cesarean section. We know that these days cesarean section rate is very high because our indications are very liberal. So we are getting so many patients of pregnancy with previous cesarean section. We will take a separate class on cesarean section. I am not going to discuss the various indication, contraindications, complications of cesarean section. That is a completely separate topic. We will discuss pregnancy with cesarean section. And we are getting many patients like this because incidence of cesarean is very high. So these are the various indications like labor dystocia, breech presentation, fetal distress, previous cesarean pregnancy and others. We are not going into detail of the indications. So why there is increase in cesarean rate? Because there is an increase in maternal age and decrease in parity. Now people are having small family, so they don't want to take chance. Neither obstetrician nor people they want to take chance. Even with the smallest, slightest indication, they will go for cesarean section. And nowadays we are doing electronic fetal monitoring. So we'll pick up the small or sometimes not significant things, and there will be one of the reason for the increase in cesarean rate. When we were postgraduates, we tried to deliver multigravida as an assisted breech delivery. But nowadays, nobody takes chance. If we explain the patient that there is a slightest chances of impacted head after coming head, then they don't give consent for assisted breech delivery. They will say, we don't want to take chance, we will go for cesarean section. So even breech delivery, and there is a lesser indication, like we are performing lesser operative delivery, that is a forceps delivery or venous delivery. That is one of the reasons. So these are the various reasons why cesarean is increasing. And when primary cesarean is increasing, we will get in next pregnancy with previous LSCs. So what are those? What is the implication of this pregnancy? So there is an effect. We will see the effect on pregnancy and labor. So there is an increase when there is a pregnancy with previous LSCs. There is an increased risk of abortion, preterm labor, other pregnancy complications, operative interference in terms of like increased cesarean delivery or increased forceps delivery or increased venous delivery. There will increase incidence of placenta previa. That placenta previa may be adherent placenta previa. There may be postpartum hemorrhage. There may be peripartum hysterectomy. And because of operative interference, there will be increased incidence of sepsis. So these are various, that's why we call it as this pregnancy is a high risk pregnancy. So pregnancy with previous cesarean is a high risk pregnancy, you should remember this. Now what is the effect on the scar? What is the effect on pregnancy of the scar? The previous scar can get rupture. So there is an increased risk of scar rupture and more risk in classical. And we have covered cesarean section in theory. Yes or no? Basically, there are two types of cesarean. One is lower segment cesarean section and one is upper segment cesarean section. When we perform in the upper cesarean section in the upper segment of the uterus by vertical incision, this is known as classical cesarean. And this classical, I can't draw or anything here. So I am just describing how much you can understand, I don't know. So classical cesarean, we give incision in the upper segment and that will be the vertical incision. And lower segment cesarean section will give incision in the lower segment and it will be the transverse incision. So in classical incision, and whenever we perform the cesarean before 28 weeks, that is known as hysterotomy scar. Hysterotomy. So more risk of scar rupture in case of classical cesarean or hysterotomy scar than lower segment cesarean section. When we talk about cesarean section, it is always lower segment transverse cesarean section until specified. Other things are specified. So what is the drawback? These scars tend to rupture. So classical cesarean section or hysterotomy scar tend to rupture during labor or in antenatal period, but lower segment scar rupture during labor only. Okay. So we will discuss healing aspect and all. So this is you can see this by this slide, upper segment, when we perform cesarean in the upper segment, there are chances of scar rupture in 4 to 9%. In lower vertical, 1 to 7%. And when we perform lower transverse cesarean section, then scar rupture is only 0.2 to 1.5%. And we perform mainly this lower segment cesarean section. So we can see incidence is lowest in this variety, and that's why this technique we adopted. So why this incidence of scar rupture is high in classical and low in transverse? So basically it depends on the scar strength. So scar strength depends on various factors. One is proper apposition. So upper segment is very thick segment because it has to produce high intensity concentration, this contractions to deliver the baby and to hold the baby. So this upper segment is quite thick. So apposition may not be perfect. But in low transverse cesarean section, it stretches during labor and at the end of the region. So here in lower segment cesarean section, margins are thin. So apposition is better. As compared to classical upper segment cesarean section, margins are thick. That's why apposition is unsatisfactory. And because of this improper apposition in classical upper segment cesarean section, there is a formation of gutter and the collection of the blood. There will be hematoma, and this will impair again scar healing. So whenever there is an impairment in the scar healing, this scar will be laser weaker. And when scar healing is better, that is scar just like in lower segment cesarean section. So there are various factors. You can get a short note on lower segment cesarean section versus classical cesarean section. And after the delivery, even for the proper involution of the uterus has to contract and relax. So again, upper segment will not be in the inactive state. It will be the contract and relax, contract and relax. So this suture line will not be in the resting phase. And in lower segment cesarean section, this is a passive segment. It doesn't contract and relax. So suture line is undisturbed. So again, if we stitch something for fracture also, after reducing the fracture, that both parts should be in immobilization state for proper healing. Same thing applied here, but here upper segment contracts and relax. So stretching, whenever there is a transverse cesarean section, this stretching will be along the line of the scar. It will be the parallel to the scar. But here I could make diagram, but I can't make. Stretching of the scar is right angle to the line of the incision. And in next pregnancy, usually placenta implanted in the upper segment. So if scar in the lower segment and placenta implanted in the upper segment, it's well and good. But in lower segment and upper segment cesarean section, that is the upper segment. So when placenta implanted, it will be implanted over scar. So there are chances of scar dehiscence or rupture. Okay, so when we see this transverse scar is sound scar, and incidence of scar rupture is only 0.2 to 1.5%, and scar rupture in vertical scar, that is classical scar or hysterotomy scar rupture is weak scar, and scar rupture is quite high, 4 to 9%. Okay, and here scar rupture during pregnancy, it can rupture during pregnancy and labor, and transverse cesarean scar rupture only during labor. So we have to do something. If it ruptures during pregnancy, we have to do something. What we will do, that I'll explain to you. Now, what is the difference in the dehiscence and rupture? When all the muscles layer give way but peritoneum intact, this is the wrong thing, dehiscence and rupture. When all the layers give way, then this is known as, except peritoneum, this is dehiscence. And when the rupture involves peritoneum also, then it is known as complete rupture. In dehiscence, peritoneum will be intact. Now what we do with this pregnancy? So basically we already discussed technical part, how we know that whether this scar is sound or not. We have to see other factors also, because when patients with previous cesarean comes to your OPD, she will always ask, this time my cesarean, you will deliver me by cesarean or by normal delivery. We have to give answer. So it not very simple ki this one patient I will tell you I will take for cesarean, another patient I will tell you okay I will for normal delivery. We have to take for various factors into consideration, And first most important thing is indication of scar. That's why obstetric history is very important in these patients. So when we take, suppose she is a G2P1 and she comes, she told my first delivery I delivered by cesarean section. Then we have to ask why cesarean was done, what was the indication. Suppose she is telling my cesarean was done because of CP, contracted pelvis. So do you think it is a recurrent indication or non-recurrent indication? Again this time it will be a CP. So it will be a recurrent indication. So first we have to see whether this indication is recurrent or non-recurrent. If it is a recurrent indication, this time again we have to take her for cesarean delivery. But suppose it's a non-recurrent indication, like last time it was breech. It is not necessary that this time she presented with breech. Last time it was done because of fetal distress. So these are non-recurrent indications. Then this type of patient will take for cesarean delivery or VBAC. VBAC means this TOLEC is trial of labor after cesarean, that is a TOLEC. So we'll take this patient for TOLEC or for elective cesarean delivery. So after these indications, we have to take into consideration of various factors, like this is basically we have to see for the strength of the scar, whether this scar will sustain the stress of the labor or not. So there are various factors that those govern the strength, scar strength. One is suppose it's a non-recurrent indication, straightforward we will go for the cesarean delivery. But if it is a non-recurrent indication, then what are the other factors? Other factors is that emergency, that cesarean was done as an elective case or emergency case. Because emergency case, there may be junior doctors operates and survive, then surgical skill may not be that good. Then indication, suppose the previous cesarean was done by placenta previa. So again in placenta previa there was a haste in suturing because there is excessive bleeding PV. So maybe a position is not that good. Okay, because of bleeding, because of hematoma, there may be scar weakening. So we have to ask for the indication. We have to ask for the whether it was done in emergency or elective cesarean. We have to ask for who performed the cesarean. We ask for the where it was performed, like in district hospital or in the medical college. Medical college maybe junior doctors operates, then there may be chances. If a consultant operates, then there are chances of. Then we have to ask for the any complications she was having in her post-op period in previous pregnancy, like if there is a history of endometritis, history of wound infection, history of blood transfusion, because poor condition of the mother is also causes the weakened scar. So we have to ask for, we have to see for the other factors that cause the effect on the healing of the scar. And we have to see the various factors in the present pregnancy. And inter-pregnancy interval is also important because scar needs at least 6 months to heal. And suppose within 6 months she conceived, then this scar will be again not good. So if inter-delivery interval is less than 18 months or especially less than 24 months, then again we don't go for the trial of labor in this patient. So before telling the answer to that patient, we will go this time for cesarean delivery or with elective cesarean section, we have to ask history in detail, because that thing will tell us whether this scar is sound or not. Then we have to take into consideration of the present factors in the present pregnancy. Suppose this time it's a twin pregnancy, so there is a overstretching of the scar. This time there is a polyhydramnion, there may be overstretching of the scar. This time if pregnancy is placenta previa, it means this placenta is at the site of previous scar, so again this scar may be weak. So okay. And suppose this time it is breech again. Last time cesarean was done by fetal distress and this time it is breech. So again we have to do for cesarean. Even in previous one was non-recurrent indication. So we have to see the various factors in the previous pregnancy, inter-pregnancy interval, and various factors in the present pregnancy. Suppose a patient, it is for the theoretical thing, we usually don't go for this. Patient comes when she is non-pregnant and she comes to you, okay, how is my scar? Then we can perform one HSG hysterosalpingography. And at the scar side, if wedge, one depression is there, if it is more than 5 mm that wedge, then we can say that scar is not good. But it's very rare, or the patient doesn't come during non-pregnant state. Usually they come when they And even if they comes in the non-pregnant stent, we usually don't advise. It is for theoretical purpose that to see the strength of the scar, one of the indication is HSG, in which we see the wedge. So means depression of more than 5 millimeter is there. And during pregnancy also, we can see the scar by ultrasonography. During pregnancy, if scar is more than 2.5 millimeter, then that scar is strength. But again, for performing cesarean section, we don't take that factor into consideration. There are so many factors, but theoretically, you should know which investigation we do to know the strength of the scar. One is HSG in non-pregnant state, and during pregnancy, ultrasonography of the scar area, and that cutoff is 2.3. In some books, it's 2.5. So so we have to ask history in detail. We have to, this pregnancy will be high risk case. We'll give usual whenever she comes in the first trimester, whatever we advise, we give in the first trimester, then second trimester advice, and third trimester advice. Then suppose we have to see her discharge ticket. In discharge ticket, if something is mentioned, suppose intraoperative the complication, there is an extension of the scar incision, it means that scar will not be good. Suppose it's a classical cesarean section, then what we have to do, that I will tell. Suppose there is an inverted T incision is given, if it is a J-shaped incision is given, then these scars we don't take for trial of labor, we straightforward do cesarean section. And regarding classical cesarean section, I already told you that in classical cesarean section, scar ruptures at the time of and during antenatal period itself, and it can rupture in labor also. But lower segment cesarean section scar can rupture in the during labor. So whenever there is a history of classical cesarean section, I am not going into detail of indications of classical. We perform the lower segment cesarean section scar. But there are 1 to 2 conditions in which we have to, like carcinoma cervix or conjoined twin. In those conditions, we have to do classical cesarean section. So whenever there is a history of classical cesarean section, we have to admit the patient at 36 weeks and we perform the cesarean at 38 weeks. But in case of lower segment cesarean section scar, we admit this patient at 38 weeks and we perform the cesarean at 39 weeks. This is regarding elective cesarean section. In case of classical, 38 weeks, 36 weeks admission, 38 weeks delivery, cesarean delivery. In case of normal cesarean section scar, when this time again there is an indication of cesarean section, then we admit at 38 weeks and we perform the cesarean at 39 weeks. It is clear to you people? So rupture of the scar during pregnancy or labor can be harmful for in classical cesarean section there is maternal mortality up to 5% and perinatal mortality is like 6 in 8, so almost 75%. But in transverse cesarean section, suppose scar ruptures, then there is no maternal mortality, but perinatal mortality is up to 1 in 8. Okay. So now all the criteria we saw by history, by examination, by seeing the patient's discharge ticket, and we decide with this patient will take for the cesarean section. So for trial of labor, there are 2 terms in this chapter. One is TOLEC, trial of labor after cesarean. So we are giving trial. Now it depends whether delivery will be achievable or not. If it is not achievable, then emergency cesarean section we can perform. But suppose delivery achieved, then we'll use the word VBAC, vaginal birth after cesarean section. So basically, again you can get a short note on TOLEC or VBAC criteria. So what are the criteria? So criteria we already discussed. Her scar, her indication, in criteria you should mention her indication should be non-recurrent. Her scar should be sound. And what are the various features? What are the in history? There should be inter-delivery interval more than 24 weeks. And she should take a small risk of having scar rupture, that is 0.2 to 1.5%. It is very important. If she is not willing to take that risk also, and nowadays we will be patient to explain why in our institute itself we are not performing TOLEC. Because when we explain to the patient that there is a 1% risk of scar rupture and there are chances of that your baby may die during rupture, then they will not take any. So patient should be willing to take that risk. And there will be 24 hours of availability of the obstetrician, anesthesiologist, neonatologist should be available, 24 hours facility for OT and blood bank facility should be there. These are the criteria should be fulfilled, then we can take that patient for TOLEC. We already discussed. Now what are the points of selection criteria? There will be repetition of the slides. When there is a one previous lower segment cesarean section, if there is a two lower segment cesarean section, then we don't take for VBAC. We then go for a straightforward cesarean section. Maternal pelvis should be adequate. There should not be any contracted pelvis or kiphlopelvic disproportion. There should be no history of previous rupture of the uterine scar, and there should be facilities for continuous and strict labor monitoring. Okay, because we have to monitor the labor. Whenever we will see what are the various signs of scar dehiscence or scar rupture. So one of the early sign is there is an abnormality in the electronic fetal monitoring. So from there we can pick up, okay, this scar is going to be dehiscent. So we will be vigilant. So there should be facility for continuous and strict labor monitoring, because we have to do partogram charting for this labor. And if there we'll see any labor abnormality is there, then we can take her immediately for emergency cesarean section. So there should be facility for continuous and strict labor monitoring, availability of the ultrasonography operating team, operation theatre and complete. Why? Because anytime we have to take her for cesarean. Because of fetal distress, that is a normal obstetric indication. Because of non-progress of the labor, because of the scar dehiscence. So it should not be like in the morning hours, OT facility is there, then after that gynecologist is not available, though it should not happen. If we are taking a patient for TOLEC, all 24 hours facility of blood bank, OT, gynecologist, anesthesiologist and neonatologist should be there. These are the contraindications. Previous classical incision, I already told you, scar dehiscence rate is 2 to 9%, 1 to 9% or 2 to 9%. And these scars are very weak scars. They used to give way in the antenatal period itself. That's why in previous classical incision, we admit the patient at 36 weeks and we do the cesarean at 38 weeks. Previous two LSAs I already mentioned, it is a contraindication for TOLEC. Pelvic, those are the same criteria, just opposite to those criteria will be contraindication. We mentioned that pelvic should be adequately spaced. Here again we mentioned pelvis. If pelvic is contracted or suspected CPD, then we should not take this patient for TOLEC. Previous inverted and T or an extension of incision, that we came to know by her notes, which has mentioned in her discharge ticket. So it is very important to ask for discharge ticket of these patients, because OT notes will tell what was happened in the OT, and accordingly we can take the decision. Malpresentation. I already told you last time cesarean section was done by fetal distress, and this time suppose it is a breach. Then breach with previous cesarean, we don't go TOLEC. So this will be a contraindication. This time suppose it's a transverse, then we don't take it for TOLEC. Suspicion of CPD, same kiphlopelvic disproportion. Medical or obstetric complication. I told you, suppose this time it is a previous cesarean, this time it is a placenta previa, then we don't go for. Otherwise, she is having severe preeclampsia, then again we don't go for TOLEC. Multiple pregnancy. I told you multiple pregnancy will cause a stretching of the effect, and this scar will be weakened. That's why if previous cesarean with multiple pregnancy, we straightforward go for the cesarean section. Patient's refusal to undergo trial, that I told you, we have to explain them possibility of the rupture and possibility of emergency cesarean section, possibility of neonatal mortality and morbidity, and if they refuse, then it is one of the contraindication for the performing TOLEC. So how patient will present? When suppose patient is in labor, okay, then how you come to know that patient is having a scar rupture or a scar dehiscence? She will have suprapubic pain. And what is the specific about this pain? She will have pain throughout the labor. Whenever there is a contraction, she will have pain. Again, relax. So she is having pain between the contraction. Even if there is no contraction, she will complain of pain. So immediately you should be suspicious about the scar rupture. Then unexplained vaginal bleeding. There will be hematuria and frequent as you pass urine, bladder tenesmus. She wants to pass urine again and again and again and again. Then you should be very suspicious about these signs, these symptoms. Then what will be the signs? There will be because scars give way, so there will be bleeding inside intraperitoneal. When there is intraperitoneal bleeding, there may be maternal tachycardia and hypotension. Because of maternal tachycardia, she will maternal hemorrhage, intraperitoneal hemorrhage. She can tell you the shoulder tip pain. She will have dyspnea. I told you one of the first sign to pick up the uterine scar rupture is in abnormal CTG. So fetal heart rate variability in terms of deceleration we can get. Then when we palpate the scar, many times during our antenatal period clinics, we taught you how to palpate for uterine scar tenderness. If it is not like taught to you people, then when you come to the clinics, we will teach you how to palpate uterine scar tenderness, because it is a very pet question of the examiner in case of previous pregnancy. And this topic as a whole is very important, because you will get pregnancy with previous cesarean in your practical exam, and you can get a short note on VBAC, on TOLEC, classical cesarean section versus lower segment cesarean section. So this topic is very important from practical and theory point of view. And when there is a failure to progress of labor, one thing is, when suppose station was -3 and this time station is quite high, we don't feel the presenting part which we felt before, now we cannot feel. So this is known as loss of station. Okay, so again these things comes in, we should be suspicious about this definitely there is a scar rupture. These are the various signs. Now there are various controversies in VBAC while performing TOLEC. TOLEC means trial of labor after cesarean section. So whether we should use oxytocin for induction or augmentation of the labor. So what I told you, that success of TOLEC will depend more on when patient comes with the spontaneous labor. When she comes in the spontaneous labor, when cervix is more than 4 centimeter dilatation, then there are more chances of delivering her vaginally. But suppose suppose we have to do induction in cases of previous cesarean, then we have to do by cervical, the gel we will apply, PGE2 gel. We never use prostaglandins. Prostaglandins should be avoided in previous pregnancy because prostaglandin causes scar dehiscence or scar rupture. We can use oxytocin for induction, for augmentation of the labor. Okay, but definitely prostaglandin is contraindicated in pregnancy with previous lesson. Use of epidural anesthesia, these are previous slides, but definitely we can use epidural anesthesia, and they say कि in case if cesarean is needed, we can continue with this epidural anesthesia. So this line I am not okay with this. In new books it has mentioned then we can use epidural anesthesia. And regarding third point of controversy is examination of the uterine scar after VBAC. Suppose baby delivered, and one of the method to examine whether this scar is intact or not, one should introduce 2 fingers in the lower uterine segment vaginally and then try to palpate. But we should not do it. There are 2 reasons for that. Suppose it is intact and by your handling it can, we can produce a tear. Second thing, if it is not causing bleeding, even if scar dehiscence is there, we don't do anything, it will heal by itself. So when after delivery, when there is a excessive bleeding PV, then yes, we can suspect there is a scar dehiscence in the second stage itself, because maybe it does not give way in the first stage, but in second stage it gave way. If patient is presenting excessive heavy bleeding PV, then we have to see, and then maybe we have to do laparotomy. But otherwise, we should not examine for uterine scar integrity after VBAC. So these are various points which will controversy, but regarding epidural anesthesia, there is no controversy. Regarding oxytocin also we can use for induction, for augmentation. For induction we can use prostaglandin, PGE2 gel, but otherwise misoprostol should be avoided. Carboprost we never use in antenatal time. Okay. So timing we already discussed. If fetal maturity is sure, suppose patient knows her date, or suppose she doesn't know her date, then she is having first trimester ultrasonography. By that there is a surety about her dates, then we admit the patient at 38 weeks and we do the cesarean at 39 weeks. Okay, and in previous classical cesarean section scar, we admit the patient at 36 weeks and we do the cesarean at 38 weeks. Because this previous classical cesarean scar, they tend to give way in antenatal period itself. That's why we do cesarean 1 week before and we admit the patient. Suppose she had rupture, so she will be in the hospital and we pick up the things early and she will get treatment immediately. But suppose any patient doesn't know her dates, it is not for classical. Okay, suppose a lower segment cesarean section, she doesn't know her dates, she is not having first trimester ultrasonography also. In that patient, whenever she goes into labor, we will wait for the labor, and the moment she will go into labor, we'll do the cesarean. Okay.